This is Jay Huang. Today we are going to use Kurt's notes to talk about anal tumors. Before we begin, if you already haven't, check out Kurt's notes website by Dr. Kurt Schaberg. He has his famous Kurt's notes as well as an About Me section, useful links and articles and books. And recently, there's been an article on the impact of Kurt's notes. And did you know in an average week, over 4,000 users access Kurt's notes? With approximately 1,000 users accessing it on a typical workday, the impact Kurt's notes has had is profound. Without further ado, let's discuss anal tumors. Benign tumors include your inflammatory cloacogenic polyp. This is a non-neoplastic polyp arising at the anal transition zone. It may involve the lower rectum, often anterior. It's thought to be due to prolapse and on a spectrum with solitary rectal ulcer syndrome and rectal prolapse. Histologically, the surface may include squamous, glandular, or transitional epithelium, which is often hyperplastic without dysplasia. Stromal inflammation, surface ulceration, and granulation tissue are often present. The classic feature is having fibromuscular proliferation around the glands, as you can see here. Squamous intraepithelial lesions, or SIL. This is non-invasive, cytologic and architectural abnormalities of the squamous epithelium associated with HPV infection. See separate lower anal genital squamous tract or the last guide for additional information. Let's talk about low-grade squamous intraepithelial lesion, LSIL. We're talking about location in the anus. It can more specifically be called AIN1, condyloma. This is cytologic atypia and mitotic figures in the lower 1/3 of epithelium with associated superficial coilocytic atypia. Atypia refers to hyperchromatic nuclei with irregular nuclear contours. And coilocytes are large superficial cells with hyperchromatic racinoid nuclei and perinuclear halos, sometimes multinucleated, as you can see here. If there is a papillomatous exophytic growth architecturally, it's a condyloma, which often has marked epithelial thickening, parakeratosis, broad reedy pegs, and coilocytic atypia. Giant condylomata acuminata of Buschke and Florenstein. These are large condylomatous proliferations and can be destructive. High-grade squamous intraepithelial lesion, HSIL. This is marked cytologic atypia and superficial mitotic figures involving full thickness for CIS or carcinoma in situ, and since this is the anus, AIN3, or up to 2/3, in that case, AIN2. Nuclei are hyperchromatic with irregular nuclear contours. There's loss of architectural polarity where you'll have diffuse buzzword block positive P16 staining. And you can screen for anal squamous intraepithelial lesions in high-risk populations such as those with HIV with anal pap smears. Fibroepithelial polyp, aka hypertrophic anal papillae or skin tag. These are non-neoplastic, benign polypoid projections of anal squamous epithelium with underlying subepithelial connective tissue. It's very common and it may resemble hemorrhoids clinically. On the surface, you'll have squamous epithelium usually, and in the core, you'll have loose fibrovascular connective tissue. And as you look closer, you may have multinucleated giant cells or fibroblasts with bizarre nuclei that are large, smudged, and or hyperchromatic, which are thought to be degenerative, akin to your ancient change in a schwannoma, and often CD34 positive. If there are large dilated vascular spaces plus or minus thromboses, consider a hemorrhoid. Paget disease. This is pagetoid spread of malignant glandular cells within the squamous epithelium and in situ lesion. You'll have large pleomorphic cells with abundant pale cytoplasm. It may infiltrate singly or form glandular structures in squamous epithelium. Clinically, the skin is erythematous and itchy. Paget's disease can be primary or secondary. Primary means it's likely derived from adnexal structures and has an apocrine phenotype where it'll be CK7 positive, CK20/CDX2 negative, GCD-FP15/GATA3 positive, and not associated with an underlying neoplasm. Secondary Paget disease, it's derived from an underlying rectal or anal neoplasm, often rectal adenocarcinoma. The phenotype depends on the underlying malignancy, but often CK20 and CDX2 positive. The management must clinically and with immunohistochemistry evaluate if this is primary or secondary and exclude rectal origin. If primary, it has a strong tendency to recur and can become invasive. Your differential diagnosis includes melanoma, which will be S100, HMB45, SOX10, Melon A positive, and squamous cell carcinoma in situ, where CK56 is positive and often block positive P16. Other benign tumors, developmental and acquired cysts, duplication cyst. This is lined by columnar organized GI epithelium with a well-formed double muscle layer and nerve plexus. Tailgut cyst, or retrorectal cystic hamartoma. This is a cystic mass near sacrum lined by any type of GI tract epithelium, including squamous, with disorganized smooth muscle bundles. Also, epidermoid cyst, anal duct cyst, median raphe cyst, mature cystic teratomas, etc. Ectopic breast tissue. The milk line extends to the perianal area, so you can have ectopic breast tissue and even breast tumors like your phylloides, hydroadenoma papilliferum. This is well-circumscribed nodule with papillary architecture of ducts lined by a double layer of epithelial cells with decapitation secretion, essentially the cutaneous counterpart of a breast intraductal papilloma, almost exclusively in middle-aged women. Malignant tumors. General considerations. If a lesion can be completely visualized with the gentle traction of the buttocks, it is considered a perianal lesion, not anal, and is similar to skin lesions on other parts of the body. Carcinomas above the dentate line metastasize to perirectal and internal iliac nodes. Carcinomas below the dentate line and metastasizes to inguinal and femoral lymph nodes. Squamous cell carcinoma. This is a malignant epithelial tumor derived from the anal squamous mucosa with keratin production, intercellular bridges, and frequent HPV infection. You'll have infiltrating squamous cell clusters and strands with malignant nuclei and eosinophilic cytoplasm. It's most common in older patients and women. HPV infection in approximately 90% of cases, and this is most commonly type 16. Risk factors include immunodeficiency, particularly HIV, anal receptive intercourse, and smoking. Histologically heterogeneous, you can have a basaloid pattern, which has marked hyperchromasia, scant cytoplasm, and peripheral palisading, reminiscent of a basal cell carcinoma, formerly called cloacogenic carcinoma. And admixed mucin-containing cells. Try to avoid using term mucoepidermoid carcinoma to avoid confusion. Verrucous carcinoma, this is bland, well-differentiated, thickened epithelium with bulbous exophytic fronds and endophytic pushing invasion. It lacks HPV cytopathic effect or significant atypia. It's hard to diagnose on biopsy, and often you have an associated inflammatory infiltrate. It's locally destructive, but does not metastasize. Anal adenocarcinoma. This is adenocarcinoma that arises in the anal canal. It can be extra or intramucosal. Intramucosal anal adenocarcinoma arises from the luminal mucosa and is intestinal type, essentially a very low rectal cancer. Extramucosal anal adenocarcinoma does not arise from lumina, meaning there is no in situ component, and may be associated with an anal glands, fistula, or other structures. Anal gland adenocarcinomas arise from the anal gland/duct. They form infiltrative masses in the wall of the anus. IHC, CK7 will be positive, CK20/CDX2 will be negative. Be sure to exclude a metastasis, for instance, from gyne origin. Fistula-associated adenocarcinomas most often arise in the setting of Crohn's disease and are mucinous. HPV-associated adenocarcinomas resembles cervical HPV-mediated adenocarcinomas. You have lots of apoptoses and floating apical mites. You'll have apical mucin, can resemble adenomas, so clues to diagnose include very low anal location and mitoses/apoptoses. All types mentioned can show pagetoid spread, meaning it's by definition then secondary Paget disease. So adenocarcinoma involving the anal canal can be primary or secondary. Primary, mucosal origin, it's intestinal, or it could be HPV associated, and it kind of looks like your end of cervical like, and both can produce mucin. Extra mucosal origin, you have your anal gland, fistula associated, non-anal gland, non-fistula. Secondary adenocarcinoma involving the anal canal, you can have colorectal metastasis where it'll look intestinal. True Paget disease, it'll look apocrine-like. Skin adnexa, non-Paget type, it looks skin adnexal, and non-colorectal cancer metastasis is variable depending on the site of origin. Neuroendocrine neoplasms. Neuroendocrine carcinomas are much more common than well-differentiated neuroendocrine tumors. Neuroendocrine carcinomas often arise from non-neuroendocrine tumors and subsequently develop neuroendocrine differentiation. Architecturally, you'll have sheet-like growth. It is not graded. The Ki67/mitotic index is greater than 20% and oftentimes much higher. It's malignant and very metabolically active / rapidly growing. And you can see this on a normal FDG PET scan. Molecular, it's driven by P53 retinoblastoma 1 and other carcinoma-associated mutations, but those two are the big ones. Treatment includes platinum-containing chemotherapy. Small cell neuroendocrine carcinoma. Morphologically, you'll have fusiform nuclei, finely granular chromatin, scant cytoplasm, as you can see here, and nuclear molding. You'll have extensive necrosis, tons of mitotic figures, and Ki67 almost 100%. Large cell neuroendocrine carcinoma. Morphologically, you'll have large rounded nuclei with prominent nucleoli and moderate amounts of cytoplasm. In terms of NC ratio, your small cell neuroendocrine carcinoma will have a higher NC ratio than your large cell neuroendocrine carcinoma. You'll have a sheet-like to nested growth, and Ki67 is often in the 60 to 80% range. And melanoma. This is malignant transformation of melanocytes present in the anal mucosa / transition zone. It's very rare, so there's no formal staging system, and typically it's in old elderly patients, more common in women. Typically you'll have polypoid masses near dentate line. Typically you'll have epithelial morphology with large malignant cells with frequent macronucleoli. You'll have dusky, grayish cytoplasm with frequent pigmentation. IHC-wise, it'll be positive for typical melanocyte markers, including S100, SOX10, HMB45, Melin A. Molecular / therapeutics, if it has a BRAF mutation, you can treat with BRAF inhibitors like vemurafenib. And if it's c-KIT mutations, you can treat with tyrosine kinase inhibitors like imatinib. However, it does have a poor prognosis. Well, thank you so much for listening in. Our rapid recall, anal tumors, benign tumors, we talked about inflammatory cloacogenic polyp. It's non-neoplastic. It's thought to be due to prolapse. Surface may include squamous, glandular, or transitional epithelium. Without dysplasia, stromal inflammation, surface ulceration are often present, and you can see fibromuscular proliferation around glands. Squamous intraepithelial lesions, you have your LSIL. You'll have superficial coilocytic atypia in the lower 1/3 of epithelium. And if there's a papillomatous exophytic growth, then it's a condyloma. HSIL, this involves a full thickness for AIN or CIS3, or up to 2/3 for AIN2. You have nuclei are hyperchromatic with irregular nuclear contours. You'll have diffuse block positive P16 staining. Fibroepithelial polyp. This is non-neoplastic, benign polypoid projections of anal squamous epithelium with underlying subepithelial connective tissue that may look like a hemorrhoid clinically. Surface, you'll have squamous epithelium usually, and core, you'll have loose fibrovascular connective tissue where on close inspection, you may have multinucleated giant cells. If it contains large dilated vascular spaces plus or minus thromboses, consider hemorrhoid. Paget disease. This is pagetoid spread of malignant glandular cells within the squamous epithelium, hence an in situ lesion. You'll have large pleomorphic cells, abundant pale cytoplasm, glandular structures. You want to differentiate if it's primary, likely derived from adnexal structures and not associated with an underlying neoplasm, or secondary, which is derived from an underlying rectal or anal neoplasm. Your differential includes melanoma and squamous cell carcinoma in situ. Other benign tumors include duplication cyst, tailgut cyst, epidermoid cyst, anal duct cyst, median raphe cyst, mature cystic teratomas, ectopic breast tissue, hydroadenoma papilliferum. Malignant tumors, if you can see it around the buttocks, it's a perianal lesion. Carcinomas above the dentate line metastasizes to perirectal and internal iliac nodes. Carcinomas below the dentate line metastasizes to inguinal and femoral lymph nodes. Squamous cell carcinoma has keratin production, intercellular bridges, and frequent HPV infection. In fact, up to 90% of cases, most commonly subtype 16. Histologically heterogeneous, you can have basaloid patterns, and you can have admixed mucin-containing cells. Verrucous carcinoma is a bland, well-differentiated, thickened epithelium with bulbous exophytic fronds and endophytic pushing invasion. It lacks the HPV cytopathic effect or significant atypia. Anal adenocarcinoma. It can be extra or intramucosal. Intramucosal arises from luminal mucosa and is intestinal type, essentially a very low rectal cancer. Extramucosal does not arise from lumina. There's no in situ component and may be associated with anal glands, fistula, or other structures. Anal gland adenocarcinomas arise from the anal gland/duct. Fistula-associated adenocarcinomas most often arise in the setting of Crohn's disease. HPV-associated adenocarcinomas resemble cervical HPV-mediated adenocarcinomas with lots of apoptoses, floating apical mites, and apical mucin. Neuroendocrine neoplasms. Neuroendocrine carcinomas are much more common. You'll have sheet-like growth in neuroendocrine carcinomas. They're non-neuroendocrine tumors that develop neuroendocrine differentiation. They're rapidly growing. Ki67 mitotic index is greater than 20%, driven by p53 retinoblastoma 1 genes, among other mutations. Treatment, platinum-containing therapy. Small cell neuroendocrine carcinoma, you'll have finely granular chromatin scant cytoplasm. Large cell neuroendocrine carcinoma, you'll have moderate amounts of cytoplasm with prominent nucleoli. And melanoma, which has a poor prognosis. Well, thank you so much to Dr. Schaberg for his excellent notes. We'll catch you on the next episode of Pathagonia. Bye.